Well, hello, everybody. And we got a special episode today with Dr. Peter, who is a pediatrician, a former Navy pediatrician, and soon to be president of the AAP chapter in Rhode Island. He's also a good friend of our list server, Peds United, a supporter of our Substack pages, and a freaking guest on our podcast. With us is also Karen Schatten, who is the associate director for the National Board of Physicians and Surgeons. She's also a frequent guest in our podcast, and she's a good friend of the podcast and George and I. So, welcome everybody, and we're going to talk about how we're going to solve some of this access to care and repetitive stress syndrome. How can NBPAS be part of that solution today? Welcome, Peter.
Yes, thank you. It's a pleasure to be here and nice to meet Karen too as well. It's excellent. Really appreciate the opportunity.
Welcome, Karen.
Thank you. So good to be back and very nice to meet you, Peter.
So, Karen, we're going to ask you since last we talked, what's been going on at NBPAS?
Sure. Yeah. Always happy to share. Our goal is always to make sure or ensure that NBPAS is accepted and an available choice for any physician across any specialty anywhere in the United States. So, the ongoing work is always identifying and removing barriers throughout any state where we might find them. So it's really important to have these conversations with physicians on the ground to hear where those might be. But there are really three prongs to our approach, and we've been working hard on all three. One, we need to engage with payers because everyone needs to get paid at the end of the day, whether you're a direct care, solo private practice, if you're in a physician specialty group, or if you're a hospitalist or a hospital employee. Secondly, we take every opportunity like this to talk with physicians, conferences, specialty societies, etc. And our message is always the same. Please consider joining and certifying with NBPAS. And the reason is really twofold. One, by certifying through NBPAS, you get a less burdensome way to stay current in your specialty. But certifying with us is also a point of advocacy. It's joining a movement. So NBPAS is a pathway. It's also a movement. And, because of physicians who have joined and added their voice to what we do, we've really moved the needle. I don't know that the other certification organizations would have made changes without some of the external pressure that we have provided since our physician founders, started NBPAS in 2015. So that's really important, these physician conversations. And then finally, we have seen sort of an increased urgency in we call it following the money, following physician data, which often links to following physician dollars. And what we are finding is the money and the data sort of flow together, and they paint a really clear picture of, where holdouts might be in terms of other organizations who are not so excited about having a legitimate competitor in the market when it comes to physician continuing certification. So, we know competition's good for markets, for physicians, for patients, for the larger healthcare system. So we have kind of a multi-pronged, tackle. And we've been working hard on all three aspects.
Great. And Peter, what's going on your end? I always marvel at how well organized the chapter is in Rhode Island.
Well,
Yeah,
th-
that you're going to be the incoming president. Congratulations on that.
Yeah, well, thank you. I mean, these are, advocacy groups and that, we work on the, for the betterment of everyone within the chapter. And it is a small state. So that's where I think where you can see the nimbleness and the ability to make some changes quickly is because of our size, so we really try to take advantage of that. But that also does mean we're talking about, maybe the same group with 10 people that tend to be doing most of the heavy lifting, and would try to, share those responsibilities and really try to give different priority to the issues at hand. And, yeah, like everyone else, we're just coming out of COVID. We're just getting back to our normal functioning as a chapter. And that's a big deal. I probably can't stress that enough, is that we've really been on our heels a little bit with, for example, this particular topic, really pushing for NBPAS for Rhode Island has been on the back burner for years now. But no, it's time to wrap these things up, refocus, re-energize, and get some things done. So I'm hopeful that I can get enough people in Rhode Island excited about this. And we work closely with the Rhode Island Medical Society, which is a much bigger group with much more resources, and and they had this on their agenda for sure. So I will be definitely reconnecting with them to see where they're moving in this, because all those issues that Karen brought up are exactly our issues. How to be actually considered board certified when you're solely certified with NBPAS, because NBPAS in the past there were issues where we were asking questions individually, at least my practice was, and we were hearing back from hospitals and certain insurers that no, we won't recognize you as board certified, and here are the consequences. And some of the consequences are things like not being able to be on staff, or qualifying for lower payment. And obviously those are huge barriers. So re-identifying those barriers, because some of them may have gone away, and then reorganizing the effort and the thought, because again, I think this is slipped out of most pediatricians' minds at this point. Survival was number one, but this is part of
Just, I guess, Rhode Island is something similar to independent practices, smaller but more nimble. And I guess New York can be compared to big systems that are very bureaucratic, and they say, no, 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 this is just the way it is. Follow what we say. So
There's some truth to that.
Yeah.
And so Peter and I disagree in a few things, but we mostly agree all the time. And I'm just done reporting BMIs. It's not that my computer can't figure out what the BMI and percentage is for the kid. It doesn't make any difference if I send it to Washington. They're not doing anything with the data. So quit harassing me about the data, because you're not doing anything with it. It's unproductive. It's a waste of time. It's a waste of taxpayer money.
Right.
I'm done with MOC.
BMI, we've had this discussion.
I'm done with MOC. MOC is a waste of time.
Yeah. I
We hear
agree.
it. We hear it from leaders in our community, like Dr. Cressley. That's not how adults learn. That is taking us away from patient care. That is a burden on the practicing physician that actually sees patients. If I'm an academic person that's on service 3 months out of the year, write books and play with rats in the lab the other 9 months of the year, well, there's no skin off my back. And I'll tell you a story. When I was an employee or contract physician to the hospital, I was the director of PALS for Northern Virginia. And I went to the big children's hospital and played with them. I did it at the school where they taught paramedics and nurses, but I was on salary. When I was out there, I had 4 other physicians that worked with me that covered the ER 24/7. The day I opened my own urgent care, I had to tell the people, children's, I can't do it for free, because when I leave the urgent care, I got to pay someone to be here, and they got to keep seeing the patients. I can't just say, I'm closed because I'm teaching PALS at children's today and tomorrow. So sorry for the inconvenience. So it's a different perspective. I'm done with this silliness of DEA asking me to spend 8 hours of my day so I learn how to use narcotics. I never use narcotics. I haven't used narcotics in 15 years.
Problem is as follows. right?
No more.
Okay, listen. The problem is they're following adult medicine protocols, algorithms, formulas, whatever you want, and they're forcing Peter to comply. Peter
George,
isn't complying anymore.
Dr. Dean, they're asking psychiatrists to manage narcotics that they
Yeah.
never. They're asking radiologists to manage narcotics, which they
It's
never.
bad medicine.
So, what is the purpose of all of this?
No purpose. Somebody made technology and they think it's good.
Yeah, and unintended consequences. There were probably good intentions to start with. For example, the DEA thing, the idea was this is part of the way to address the opiate pandemic, and obviously it's wrong-headed and it should be better directed. And they have, in some ways, developed, at least for pediatricians, some training that's pediatric specific. And it was so interesting. It's not nice to be forced into doing that type of thing, but for me, and I get it, when you have multiple of these things, eventually, especially again, the main message to everyone should be, our healthcare system almost died. The pandemic almost killed us. That message is, people have forgotten this whole thing where, the New Yorkers used to come out on the balconies and applaud the doctors and nurses coming home. That injury and that problem just doesn't go away from one day to the next. And so instead, they should probably just spend as many as possible shopping for doctors, I don't know, 2 or 3 years. Why not do that? If I had a magic wand, let's just suspend some of this food shopping nonsense. And there is a lot of food shopping. And what George was saying is correct as far as the adult model, when you're describing about value-based payment, that's coming right from CMS and Medicare. And Medicare has no implication on how we practice. We're just getting shoved into that square peg to get paid. That we have no increase in fee for service. If you want more money, you have to do value-based. If you want to do value-based, you've got to report whatever the heck they tell you got to report. And it's big systems. And, Rhode Island trying to object against this big system is not going to work. Never mind my practice. So there are some hoop jumpings that I just have to kind of take on the chin. But when I can, and we have the opportunity to push back, we should. And so while I agree with everything we're about to say, those are all very valid concerns. What are we going to do about them? Well, for Vermont, I think there is a path forward. It just makes this is self-inflicted. This is us. The government doesn't necessarily want to tell us how to board certify. They're happy to have us self-govern. Let's do that right. Come on. That's so basic an issue. We're getting in our own way. And either people are somehow misunderstanding the situation or benefiting from the situation. Those are the only two reasons why it continues.
So the misunderstanding part, Peter, is a general doctor thing. It has to be perfect. It has to be analyzed, super analyzed, and deducted. The other people that are benefiting is who? The computer companies that create all that technology that's super expensive. I'm doing the MOC right now. It's really impressive technology what they got there.
Right. But I bet
it has to be paid.
The biggest issue is it has to be paid, but the biggest issue is transparency. I don't know. My feeling is from what we can gather from what is public is that there's a huge war chest right now of money at the American Pediatric Board level. Never mind the national, but the American Pediatric Board level. They have a huge amount of money that they're willing to spend on all kinds of research that we have no idea about. We don't vote on, we don't review, it doesn't affect us, and it has nothing to do with recertification of doctors. It's their boards. Their board decides what they spend, where they spend their money on what research. And of course, as we all know, the very obvious things where it's kind of becomes almost embarrassing and somewhat unethical and dangerous is their own salaries and their own benefits. There's no oversight of this. This is not okay. Unless we're completely wrong and we have the wrong information, they have a lot of money. What are they doing? So forget about the cost because apparently they have tons of money.
The interesting thing is I can't hire pediatricians because of loan forgiveness that they can't come to my office because I'm not a federally qualified health center or a non-for-profit or whatever nonsense.
Okay. What is it? What isn't the board start a loan forgiveness program?
They did. They made a whole new loan forgiveness program that they did, but it's only good for specialists.
Well, that wasn't the board. That was the AAP government and the government working together.
We're talking about the ABP, which is a standalone not-for-profit organization where the pediatrician CEO, now everybody's the CEO, and I am the CEO of this podcast too, co-CEO, George. And he pays himself $800,000 a year, while the starting salary, according to Sue Cressley, for a pediatrician in Wisconsin is $120,000, and the starting salary for a pediatrician in Rochester, New York, is $140,000, and the starting salary for a pediatrician in Northern Virginia is $160,000, and you cannot buy a townhouse for less than $600,000 in Northern Virginia. That is a crime committed by one of us against all of us. And they have millions of dollars in reserves that they could use to help young medical students who are passionate about pediatrics get free medical education. That is part of the solution to our shortage of medical primary care physicians. Eliminate the burden, eliminate the debt, and give them a good salary so they can do what they want to do, which is to take care of patients. That goes for internal medicine, family practice, and pediatricians that are in the front line of taking care of people in their communities and in their neighborhoods. It is a crime committed by our own people against us.
Yeah.
So,
And then we do have those that are just misinformed, and we do have well-intentioned, sort of pediatricians and leadership physicians in academia that just really don't, they really view the mock as, why are you guys complaining? It's a really good way of, staying with your, keeping up your skills and thinking about problems. And, we're on the same team. You don't seem to understand that, that when you're not in academia, that these are big costs and a big time suck. And we don't have the time to donate to these extra efforts. Like, almost every other part of the mock, besides the computer-based learning part, which is actually a good thing to develop. It's not like they can't do good things. The Mocha P part of the mock is not a bad thing. I actually think most of my colleagues would enjoy it. It doesn't have to be the cost, and it could be the only part, and again, so that's the one issue. There's a jumping issue of doing the mock versus the financial transparency issue. Both are big issues. I would argue the financial transparency issue is the biggest issue, because there's just tons of money just sitting there, and and we have the folks that have no accountability, that could make changes tomorrow that could affect all the pediatricians in the country, and because they want to. Why would we have that situation where folks can just make these decisions because they want to? There's no formal pathway to becoming the CEO. It's just whoever they decide. How is that a reasonable thing that one person can just be king without any kind of true election and without any accountability? It was completely benign.
I wasn't born in the U.S., right? And although I look old, I'm not as old as America is. But there was some king, I think King George, he's called, who got into a war because of taxation without representation.
Well, there's so many good issues being raised here. And I think, Peter, you said something about, the money, how is this okay? And I think, one of the most important points that NBPAS likes to focus on is ABMS and AOA are non-profit 501c3 organizations, which by law, under IRS law, are supposed to be public charities, right? They're supposed to be public charities. I know the American Board of Pediatrics has a ton of money in its war chest, and that's just one, and it's certainly not the biggest. If you look at ABIM, you're talking about hundreds of millions of dollars. And this is physician money from doing MOC. And I always like to take it back, especially when we're talking with physicians, because you guys know how to read data, interpret data, and say, is this clinically proven or not? And so when anyone says, well, but it's here, yes, computer programs can be impressive. Technology can be, wow, bells, whistles, this is exciting. Does it improve our patient care, our clinical outcomes? Does it make better physicians? And the data says, after 20 years of trying and trying and trying, the answer is no. There is no level A evidence that suggests any of those things. So those dollars are being required, made, saved, spent in ways that physicians have no control over. So, one of our big goals is just to constantly, remind everyone. And I think it's really hard for physicians, because physicians are naturally trained to constantly learn and study. And so you almost feel, I had a psychiatrist tell me, they believe this was their theory, that physicians sort of have a psychological drive. You feel like you're doing something wrong if you're not taking an exam or taking a test or somehow proving yourself, right? But again, the data, right? When I bring my child to the pediatrician with a sore throat, she's not going to get antibiotics unless she's positive for strep. Why? Because of the data. We know it's why we don't give unnecessary treatment to patients. Ideally, why would we require unnecessary modules for physicians? And so it's one of the points we really try to educate people on. And I think, Peter, your other point is really, really good, that some of the people in the academic positions really are very well intentioned. I spoke to an anesthesiologist recently on another podcast, incidentally, and she said, when I was young, there was so much excitement about, like, I'm going to be a board examiner. I'm going to submit questions. I'm going to be part of this process. And she said, but then, 10 years down the road, you look back and say, these organizations have really lost their way. I don't want to be a part of this anymore. And so I think part of it is, as physicians going through residency, the initial board certification has tremendous value. That's what makes you the pediatrician in this case, that you are. That is your specialty training. That is a very stellar, very impressive, and very meaningful credential. Unfortunately, MOC is completely separate and it's a different product. And I want to emphasize and underline and bold product. It is a product and it's an unproven one at that. And so, the more we can clear the pathway and relieve the burden for physicians, that's what we exist to do.
Yeah. And Karen, because this is a problem for us, right? So pediatrics is only 30% white, only 30% male now. And it's a woman problem then, because 70% are women. When they're leaving the profession 4 to 7 years after they start, they're just exhausted. And George complains about it. Peter complains about it. Kathleen complains about it. Nola complains about it in Alabama. We can't find pediatricians to hire to see the kids. I mean, George has got 25,000 kids in his roster with, more than half of those being kids on Medicaid or CHIP, and he can't hire a pediatrician. And the problem here is that when we're made to jump through hoops and do repetitive actions that don't improve the care of our patients and that don't change anything that we're doing, that leads to physician disengagement. And we cannot have any more of our colleagues die by suicide. We cannot be using women pediatricians the way we are. And we not only have to address the debt burden, the inequity in salaries, but we also have to stop asking them to do things that don't improve the care they give to their patients. I think NBPAS has done some studies or has some data that shows this also leads to physician disengagement. Am I correct?
I'm not sure what you mean about data or studies, but we know, from, we work with physicians day in and day out. We hear from them all the time. And so, we know physicians are exhausted and burnt out and have no gas in the tank at the end of the day, the week, the month, the year. And, I know one of the questions you're curious about, Herb, is, so why isn't NBPAS everywhere? And, the answer is because physicians are exhausted from seeing patients and they don't have time in their schedule to go out and start lobbying and, becoming political activists. It's a very, very exhausting and tiring job. And so that's what we work on, from the administrative level of, trying to clear the pathway. But I think what we've learned is the majority of physicians we talk to would very much want to certify with us. And the obstacles are not with certifying with NBPAS. The obstacles are systemic, in the structures. So, Peter is in Rhode Island, so it might be perception of hospitals in Rhode Island. And so that's what we work very, very hard to turn the tide on. I think to Sue Cressley's point on I don't know when you recorded that other episode, she said physicians are dying a death by 1,000 cuts. And I think another message that physicians, not just MBPAS, but physicians must advocate for is ABMS and AOA, they'd like us to believe that if you don't participate in MOC, you're going to be a lesser physician. You are somehow not learning. You're somehow not staying competent. And I sent out an email just to 10 of our physicians that I know well. And I said, could you please send me a list of every quality program, every education, every data collection that you participate in, whether some of them are private practice, some of them are hospitalists, very, wide variability among specialists. I have a 2-page long list, weekly case conference, monthly case conference, morbidity and mortality, complication reviews, protocol writing, student teaching, mid-level supervision, council meetings, quality meetings, performance, peer review meetings.
Sounds like my life.
Yes, right. Quality conferences. And then depending on your specialty, your pediatricians, I don't know what national, incentives there might be for, reporting that your children are all vaccinated and you're meeting these benchmarks for diabetes screening and so on and so on and so on and so on. Your life is quality improvement. you have signed up for a career of lifelong learning and education. It's not valid. And we know the data shows again and again and again, there's really no validity that doctors, have to participate in MOC to become and maintain their lifelong excellence. And so, it's an education job, and we have it one conversation at a time.
Aaron, I have a question for you.
Sure.
I maybe just missed in the beginning of the point you were just making. Who are those people that are saying to you that physicians, if you don't participate in a mock-like process, maybe not the mock product, but a mock-like product process, that you're not engaging in lifelong education or training?
Well, I think so. I think it's general messaging and
Okay.
PR marketing
Yes.
that I'm talking about. And I'm talking about that from the mothership. And when I say the mothership, I'm talking about ABMS. And there's a lot of PR and marketing. And maybe I'll just pivot to that. About a year ago, in fact, a year ago tomorrow, we announced that NBPAS had been added as a designated equivalent source agency by the Joint Commission. It was big news. Everyone was really excited. It caused a lot of excitement. Our numbers jumped up. About 2 weeks later or less, ABMS released a press release. And then shortly thereafter, something called a toolkit. And we are pretty confident that it went to state medical boards, specialty societies, specialty organizations, all their member boards. Nobody wants a substandard physician, right? Nobody wants a non-current physician. So it is our opinion and position. This is really good marketing, and marketing is not science, and marketing is not medicine.
Yeah, Karen, I couldn't agree more. I think that's some of the pushback I initially got when we were sort of just grassroots. This was like years ago now, maybe even 10 years ago, where we were grassroots, sort of as the AAP Rhode Island chapter is very much just a group of pediatricians. We're saying, what is going on? When the mock first got modified, we're like, this is just doesn't make sense, and when they still had their, in a service test center exams that you have to take, go sit for an exam in a closed box. And it was just horrendous type of situation. We're pushing back. We did get a lot of pushback from, people who are not benefiting from, financially from the mock in any way. They really believe that this lifelong learning thing is essential. I was definitely getting that message loud and clear. And I was like, but why? I mean, I can explain what we're doing. Like, I get your idea, but let's look at what we're actually doing and tell me how this is this really making, doing anything besides job? And it was a little bit of a back and forth, and I was shocked. There was pushback, but there was pushback, mainly from the hospitals and from the hospital leaders and from the physician leaders of the hospitals. So I'm very interested if you could send us a link to that toolkit, to everybody, to the,
Yeah.
just so we can share that information, because I am definitely taking this to the Rhode Island Medical Society, and I'm sure they're pushing for it because I know they have been. And whatever the barriers are, I'm going to work to try to minimize those barriers. So everyone has the option to think about if they want to pay for the mock, or if they want to do and be passed and be board certified. If we get to a situation where we have that choice to be, viewed as board certified with either the mock or the NBPAS system, let the people choose. And I think it's going to be a very quick exodus. That's my perspective. But
Well, I agree. And, I like to emphasize that MOC is a product. And if it was true, it's supposed to be voluntary, but in reality, it's become a de facto requirement to practice medicine in the United States. And, one thing I like to say to people is if you have a really good product, you don't need to force people to buy it. I don't need to force anyone to buy an iPhone. Everyone goes out and buys an iPhone. We don't drive Model T Fords anymore. Someone's invented and innovated something new. NBPAS is an innovator and a leader in a way that we are reducing burden and trying to do it in a much more efficient way. I mean, every hospital in the United States should be banging on our door for this, because on average, our certification with NBPAS is about 72% less, right, than participating in MOC. I think the statistic from the end of 2022 from the American Hospital Association is nearly 80% of hospitals were ending 2022 year in the red. People are looking for every cost savings, and with so much emphasis on value-based care, I don't this in a sense is a very value oriented option, and it's a good option, and it's it's a rigorous option.
And does NBPAS have a dedicated website or source where folks can review the financials? I know you have to publish it. Those things are not as easy as you think to find. I remember when I did research on that, we found the information, and then even interpreting it was a little bit difficult, and where I was getting pushback on how I was interpreting it. And I'm not a lawyer, like that stuff is challenging.
Yeah,
Like,
yeah, absolutely. We believe in transparency, full transparency. I believe our 990s every year are published on our website, and I'll double check that to make sure I'm speaking correctly. But all our data is there. We don't have lobbyists. We don't have in-house lawyers. We are a true nonprofit. I like to say we burn what we earn. None of our top leaders, none of our top leaders in the organization clear $100,000. We're all making less than that. We are here to truly serve physicians, their patients. As just a lay person in society, I see the crisis. I see the crisis as a patient with my own doctors. I see a crisis with my own pediatricians and my children burning out and wanting to get out of medicine. This is not a problem. This is a problem that can be ignored, and it can't be marketed away by organizations with lots and lots of money. This is a pediatric specific program, and I shared with Herb and George, I believe last time, I had a friend who worked for the American Board of Pediatrics, not in a medical capacity, but in a technical capacity, and described their headquarters as the Taj Mahal, and said they didn't know what to do with their money. Food carts, mahogany paneling, artwork, gourmet this, time off at Christmas. But physicians don't know this information. It's conscionable. It is unconscionable. So the more that every physician can stand up, join NBPAS to add their voice to our important work and mission, amplify these stories like George and Herb do on this broadcast, it's critical. And, we really, really exist to support physicians. Physicians take care of us, and I mean us, everyone. Physicians care for people, and NBPAS, we truly want to support physicians in this very hard work.
I would consider this outside your scope, to be honest, but maybe it's something you do provide. Do you have like legislative liaisons or advocacy folks do you do that? Like anything official like that I can contact, or is it more like just unofficial?
You mean in-house?
Yes. You guys have like a division of legislation advocacy, because
So I'm gonna
What are the-
I'm gonna explain to Karen a little bit. So,
okay.
for example, the American Academy of Pediatrics has its office in DC.
Okay.
It has lawyers and all the staff that are supposed to advocate for things that are important for children. And so, what Peter's asking is, do you have an advocacy office for NBPAS that has a template for us to use?
Sure. So you would be talking to me. You're talking. I am the department. And yes, we could certainly talk later or at a
Okay.
good time to talk about whatever you might need, Peter.
Okay. Because that's definitely going to happen.
Yeah. And that's, and I always like to say that's really how true nonprofits often run. Lean, we're lean staffed. We wear many, many hats. So I can change my hat and on a moment's notice and work on what needs to be done.
I'm in a level set a little bit because this is not just a pediatric problem.
Sure.
So, on the average, a big health system, whatever that health system is, lose $100,000 to $150,000 per year on primary care doctor they employ. Um, Health systems are not very efficient, and so it's very difficult for them to be in a low margin, high volume business. I just talked to some friends in Columbus, Ohio. The local hospitals are trying to find internal medicine doctors. They're starting them at a salary of 200,000 a year and $100,000 sign-on bonuses, so they can retire some of their student debt just to get an internal medicine doctor. You're not going to make that back on revenue. It's impossible. And we've already addressed how people are leaving just because they just can't stand it anymore. It's like, let me take care of my patients, or just I'm leaving. And it's affecting my friends, my adult friends. They can't get into an endocrinologist. It's affecting My dad, he called for his cardiologist appointment. They said, we'll see you in November. It's affecting the children. Good luck trying to get a pediatric neurologist in Northern Virginia. They don't even have a wait list anymore. If you have a seizure, send the kid to the ER. The rounding doctor will see him in the ER, and then they'll get a clinic appointment.
That's what we used to do in the 90s.
If you want to see a pediatric psychiatrist, despite the fact we have 3 or 4 medical schools within driving distance, the current wait list is 2 years. And we need to do everything: loan forgiveness, better payment for primary care doctors, more respect for primary care doctors, less hoop jumping for primary care doctors, so that we can have healthcare.
I think, you can't fight every battle, but, the AMA is complicit in a lot of this because they generate all the coding. And though they lobby as if they represent all physicians in the United States, they actually, I think at current counting, their paid membership in terms of actual attending physicians, it's just shy of 12% of physicians in the US. That is nowhere near a majority. And so again, following the data, following the dollars, paints a picture that no one is really advocating for what matters, but you guys are advocating for what matters. NBPAS is advocating for what matters. And so these are the important conversations of how we move
Yeah.
move
And
forward.
and historically, to make changes, a lot of these are government. There isn't a free market in healthcare. These are government, everything's government regulated, so, and the people who are donating, the physicians that are donating to politicians are not pediatricians. These are the surgeons and the surgical groups and the big groups, and they have money talks, and they get listened to. And we don't. And it's not a respect thing. It's a money thing, which is common for all these things. I mean, some of these big bullies are run by moms who love their pediatrician. And a lot of the doctors that I talk to that are more in my generation, I'm not doctors, I'm sorry, but administrators that I talk to, government officials that I talk to that are my generation, who are now in charge, they love their pediatrician and would never, it actually does help it does win us a lot of points, a lot of respect when we bring up, the pediatricians are in peril, and I can convince them. But the idea of connecting their pediatrician to the pediatricians in the state and what's going on with pediatricians for everyone is a disconnect. They're all about their pediatrician, but you guys can go see a nurse practitioner. It's cheaper. And that's a very big disconnect. That's another struggle. Yeah. What's good for me isn't what's good for everybody all the time. And there's a lot of different interests and influence, and the money's slugging, and we're not putting in the money, and we don't necessarily have the money to put in. And right now, we don't have the energy. We don't have the people that are going to come out of the woodwork to start fighting some of these points for it. Okay?
Who's supposed to do that?
Yeah. We can only advocate for ourselves. I mean, that's it.
Well, and somebody asked me once, what would it take just to just have a landslide for NBPAS, on the turn of a dime? And I said, every physician simply say, no, I'm not going to do MOC. I mean, could every physician in the US be fired? Could we, nobody could function, if it's truly voluntary, because that's what ABMS will say. They say it's voluntary.
Well, the problem with that problem and the psychological issue. Mainly physicians are getting to answer the call to be physicians because we feel like they're servants. We feel like we serve our patients. Doing something like you just said would feel like way too much like abandoning our responsibilities. And that just is such a high ask for physicians, especially pediatricians, even more so pediatricians, I would argue. That just will never happen. We would almost be publicly flogged in the street.
Oh, yeah. Oh, I would never want you to abandon your patients, Peter. I'm
not even saying, I'm not saying you're saying that. I'm saying that's their
it would be
agree with
fun.
that.
Yes.
It's their it's other folks' psychological, sort of what they hear from them. Stop doing the mock. Don't get board certified. Put your board certification up risk. Those type of thoughts are just way too, provocative for most pediatricians to even remotely consider. So this idea of some kind of mass exodus would just not fly.
It doesn't have to be a mass exodus. We are right. Pediatricians are extremely conservative which is odd because in social agendas, they're very liberal, but it's behavior, we're very conservative. And we don't want to rock the boat in any which way. You know, we
Avoiding risks.
we don't want to give a child antibiotic unless they really, really need it because they might get diarrhea, they might get anaphylaxis, you know, always doing less is better with kids. And so that's just our nature. But I could bet you almost $10 that if half the pediatricians in Rhode Island wrote a letter, they all signed it together to United Healthcare and said, as of January 1st of 2024, none of us will continue with MOC. We're going to NBPAS, and we urge United Healthcare to adopt the military and the FAA process, which is if there is an event, a near miss, we will all review it and we will all learn from it. But if you need to kick us out of your contract, January 1st, 2024 is the date.
Well, it's not even a thing. This is United not is National United not recognizing
Like
NBPAS.
state by state.
I don't
Yeah, I
believe
can't.
it has, to tell you the truth. I
Yeah, I
think
can't.
it's just the message that's out there, the boogeyman.
Yeah. There's a lot of misunderstanding on the payer side. We have many MBPAS physicians who have really good relationships with United Healthcare, United Health Group. And one of the most common misconceptions out there is there's a difference between board certification and verification of board certification versus what's called primary source verification, which is what all insurers require. It's what the national accreditation standards require, which simply means that whoever is looking at a physician to credential them, whether it's a payer for enrollment in network, whether it's a physician for employment in a hospital or a job, you have to verify their credentials from the primary source. And what was so important about NBPAS being added as a designated equivalent source to the Joint Commission is we are now an equivalent pathway to verify that for physicians. Many, many major payers are agnostic to board certification status. But because board certification is the highest level of education and training for most physicians, it simply needs to be verified as part of the credentialing process. So rank and file credentialers will look at their policies and procedures and they'll see verified through ABMS because ABMS is a primary source. It does not mean they require ABMS. It means they simply need verification of board certification. That's why we have these conversations, Peter, because very often, and we're finding a lot of favorable outcomes where payers say, no, you're fine. You're fine with NBPAS. Just let us know. So I can't answer specifically for Rhode Island because it can vary state by state. I'd have to look into it, but we do have success. We certainly do have success with that. I think, I want to circle back to one really critical point that Peter brought up, which is physicians don't want to give up their board certification. And that's really the kicker because physicians should not be able to be stripped of their board certification credential for not participating in MOC. And that's not just the position of NBPAS. The Department of Justice weighed in on a piece of pending legislation in the state of Maryland for us back in 2018. And they said physicians should not be allowed to have their credential removed. And I always use the analogy of lawyers. If you told a lawyer you were going to remove them from admittance to a bar in their state after they passed a bar exam, it would be like DEFCON 1. They would never stand for it. Why would anyone be allowed to strip your credential? I've graduated from high school. I'm a high school graduate. I've graduated from college. I'm a college graduate. I've graduated from law school, med school, fill in the blank. You are a graduate. You graduated from residency. You passed the board exam initially. You are a board certified physician. MOC, continuing education, we believe should be an entirely and completely separate credential, which speaks to that point you make, Peter, which is, look, you're not giving up board certification by coming over to NBPAS. You are becoming certified continually through NBPAS for phase 2, which is the lifelong learning and that part of your career. So that is, an area we work really hard on. It's a complex issue legally, but it's a really important one for us. You are board certified. Why should anyone ever be allowed to decertify you? And the fact is, to Herb's point, I can't speak for every member board of ABMS, but I know that some of the ABMS member boards absolutely list physicians as not certified and will remove them from their database for not participating in MOC. And we think there's some serious problems with that.
Well, Peter, when you start doing this, let me know what I can do to help you.
Starting next month. And I'm definitely going to work with Karen on this. That toolkit, that DOJ communication that you just mentioned, those would be two very powerful pieces of information for me as I fight this fight. So put that out on the listserv and the podcast and the Substacks. And certainly I'll be taking advantage of that.
Terrific.
All right. Well, I want to thank everybody. This is a very important conversation.
Very heated.
And very heated. It's always heated because it's emotional.
Yeah.
I mean, we need physicians.
And it's so frustrating because it's self-inflicted and not necessary. It's not like there isn't two sides to this. There just aren't. It's so obvious that this is an issue, and that frustrates me more than anything else.
Well, we do the future of the country, which is
But we are the future of the country. I mean, we'll become people with problems if we don't fix them.
Yeah. Become big people right in front of us. Yeah.
well, Peter. We'll let you go on to your boat.
It is a nice day in Rhode Island.
He's going on the boat. I'm going back to save the world. One kid at a
And how about you, Karen? You're going to the pool next, I guess.
No, my day is only about half over now, so we'll dig in and see what other good fight we can fight, and really try to keep the ball rolling. And really appreciate all your great work, not just taking care of kids everywhere as pediatricians, which I really do appreciate as a mom, but your advocacy to talk about these issues and to put energy into helping your current physicians and all the physicians that will come later. I think it's super important. So thanks for having me on again.
And I see Dr. Bravo is dressed up like us, Peter, saving the world today.
Yeah, I'm working today.
You're working today. You're the busiest unemployed physician I've ever seen.
That is true.
Yeah.
Well, Karen, thank you because you and NBPAS is really doing a great job. And Peter, thank you. You know that you and I disagree on the value of certain organizations, but I think the leadership and the work that the pediatricians in Rhode Island put for their community as physicians and their children is admirable. And I don't think it's the organization. I think it's you and your fellow pediatricians in Rhode Island that are an example to be admired, applauded, and thanked for your care for your children.
Yep. Well, thank you. And thank you for the opportunity. This is very helpful for me. I appreciate it.
Great. We'll see you all soon. I got to get back to seeing patients.
Okay. All right. Have a nice day.
All right. Bye bye.
Bye, everyone.